All right, welcome everybody. Thanks so much for attending today. My name is Max Ferrero. I'm the studio manager at Mint Condition Fitness. I want to start by thanking Dr. Stephan and the doctors at the Los Gatos Doctors Group for teaming up with us on this presentation, bringing a fitness studio and a medical group together to talk about GLP-1s is a conversation that we think needs to happen. And today we'll hear from Dr. Stephan first, and she'll educate us on GLP-1s, and then I'll join in to talk about what's most important for people who are taking or considering taking GLP-1s. So here's Dr. Stephan.
Good morning, everybody. I'm Dr. Natalie Stephan.
Here, you need this.
Oh.
There you go.
Hello. Good morning. I'm Dr. Natalie Stephan. I'm with the Los Gatos Doctors Group. My partners are over there. Dr. Kathy Shade and Dr. Tiffany Davies. They've been in this area, I think, for 20 years. I recently joined their practice about a year ago, and I love it because I feel like we provide amazing care to our patients. This is our future doctor, my baby girl. No pressure on her. We are a concierge family practice. We take care of our patients. We provide personalized care to our patients and really get to know our patients and their lives one-on-one. And one of the things that we commonly hear about is GLP-1s and the need for weight loss or weight maintenance. So GLP-1s, I think you guys have heard some of the medications, Mounjaro, Wegovy, Trulicity, Zepbound, Ozempic. They've been around for a while, but they started picking up a little bit of momentum the last 5-6 years. Okay, what are they? They're technically hormones. Hormones are anything that flows in our body from one organ to another. They are hormones. They were identified in 1970, so we've known about these hormones for a very long time, but didn't really understand exactly what they do until more recently. They affect almost everything. So they both come out. So there's GIP, which is the one we found in 1970s, and then GLP-1, which we found in the 1980s. They come out from the intestines. So after you eat, your sugar goes in your intestines, and then they stimulate these hormones to be released. And they literally go everywhere. They go into your pancreas to start releasing insulin. They go into your stomach to say, slow down. They go into your liver to start affecting how much sugar gets stored in the liver and how much fat gets metabolized. They go into your kidney to how much sugar gets pushed out and how it's metabolized there. There's been more and more findings of how it can go into your fat cells and potentially reduce how much fat deposit gets into your fat cells or the adipose tissue. And then, interestingly, there's been more and more information that these hormones, because they are hormones and they go into your bloodstream, can even affect your brain and rewire the brain. And for some people who have difficulty with, I'm just craving food all the time. I feel like there's so much noise in my head. It's the food noise. That these hormones play a role in that. We all have these hormones. They're natural. They're in us already. It's just these medications play a role with affecting how those hormones work. The other thing we're recently finding out is it also has cardiovascular protectiveness. So it can, one, because when you lose weight, your diabetes, if you have diabetes, your A1C level goes down, your cholesterol levels potentially go down, and that can obviously help your heart health. But they're also showing that there's ways that these hormones play a role in your heart. It is in your bloodstream, so it's touching every single organ, which I think is really cool. But I like science. But I think one of the studies was saying that with the GLP-1s, taking it for 3 years, you have an 18% reduction of cardiovascular disease, which is pretty significant. And that's compared to a placebo group. Okay. Good morning. So whenever you talk about medication, you want to talk about side effects. Biggest side effects, the most common, like the main ones are semaglutide and tirzepatide, nausea. Up to 40% of patients will experience nausea. Generally, these are dose dependent. and usually the first 8 weeks, and then after a while your body gets used to it. But the most common complaint we hear is nausea, or you're feeling nauseous and you want to throw up. Some people even get diarrhea. Again, it's affecting your GI tract. It's slowing things down. When things slow down, things aren't moving down. So things up here make you feel nauseous. You want to throw up. So things we say is, don't eat a late meal at night. Try not to like lay down immediately after having food because the food isn't going to move fast. Some people ironically get diarrhea. Again, this is hormone, so it affects the intestines a little differently for everyone. So depending on what symptoms you have potential on these medication, you can kind of counteract it. So if you have heartburn, don't eat spicy food. You can try antacids. If you're having nausea, try to limit food eating late at night or having big meals, maybe spacing it out into small little meals, portion it out throughout the day. Usually the symptoms wear off by 8 weeks. And then whenever you increase the dose, the symptoms kind of pick up again until your body gets adjusted to the dose. But everybody is different. So work with your doctor, figure out what symptoms you're having. Are your symptoms getting better, or are they getting worse? Are they making your life miserable? The goal of these medications are meant to help you. You have the hormones in your body. These medications are meant to make the hormones better and work better. Of course, another warning, I always say this, because of these medications, it's just do not take if you have any history of MEN type 2 or some multiple endocrine neoplasia type 2 or medullary thyroid carcinoma. Your doctor will ask you, but if you have any cancer history or any family cancer history, always tell your doctor because every medication, it will touch every organ. Just something to remind you of. Yes.
What about like as far as any other patients that you would not recommend? People with mental illness, people with gallbladder disease or pancreatitis.
It's like you read my slide. There's not a direct study that's saying do not take if you have gallbladder disease or pancreatitis. It's more if you've had a history of, just be cautious. So if you're starting to have symptoms, like, oh, this is starting, my abdomen is starting to hurt and it's pushing to my back, or every time I eat, it's really starting to be painful, then it's more go see your doctor right away, get an ultrasound, get blood work, get something tested just to keep an eye out for. So you're more aware of potential side effects. Great question. As for mental health, it's not a complete barrier. It's a discussion with the provider. Everybody's mental health is a little different, and how it causes medical conditions and how it can restrict your medical condition. So it's more of a discussion, which is why it's always good to have a good doctor. I really believe in that. Okay, meds. So these meds are becoming more fascinating. It used to be just GLP-1s. So these are the semaglutide and the liraglutide. Up to 5 to 10% weight loss with these medications after taking it for about, I think it's like 60 weeks. So yeah. There's now the double therapy. Remember how I said there's like two hormones, the GLP-1 and GIP? They affect a lot of different organs. They actually target a few other things. So tirzepatide also came out with a combination up to 20% weight loss, which is really interesting. And this, whenever you're talking to your doctor about wanting to start on these medications, end goal is always important. So how much weight are you planning on losing with these medications? So if you're planning on losing about 10% of your weight, okay, something more gentler, one hormone, that's fine. If you're planning on losing a large amount of weight, maybe double therapy. But then again, that could also mean more symptoms. So it's a plan. You have to plan it out. Recently, they're coming out with a triple therapy. So there's the GLP-1, GIP, and the glucagon receptor agonist. It's still being tested, so I would not recommend trying it. I'm always wary of new medication just because we don't have the full side effect profile and long-term complications. But it is in phase 3, and it looks like 24 to 29% weight loss. And I think in one recent study on the Hippocrates, they were saying the trial phase says even up to 40% weight loss in, I believe it's 60 weeks. So it's pretty impressive. But again, I personally am a little bit cautious because it is a new medication. I'd like to see more data on it, but there's more studies that are showing that it is helpful. And again, these are hormones that we naturally have in our body. It's just activating these hormones and making it more effective.
Is the main benefit then that it makes them more effective, therefore you lose weight, or you just don't want to eat as much, or
It's a combination. So it does make them more effective. It allows your insulin to be more productive, hits the receptors exactly where it needs to hit. It also, the nice thing about, because it does play a big role with insulin, it also affects glucagon. So once your sugar level gets really low or to a point where you don't need any more insulin, it automatically turns it off. So you're not making too much insulin and causing the hypoglycemia that we worry about, and your sugar levels get really low and we worry about you fainting or worst case scenarios. So these medications are really good. If you have diabetes, it's obviously for type 2 diabetics. Type 1 needs the insulin. It's a different category. If you don't have diabetes, we're noticing that this helps a lot with insulin sensitivity, insulin resistance, because that's something we're seeing more and more nowadays, where your body is just, you're producing insulin, it's just the body's response to insulin isn't as robust or strong. Then we're also noticing that the way it affects on the intestines, it slows the movement down. So when it slows the movement down, then you're not feeling as hungry. Your food is staying in your stomach a lot longer, so you're feeling fuller for a much longer period. And then because the hormones also affect your brain, it affects the receptors in the brain because it is a hormone. So it'll change the way the wiring is in the brain to say, maybe I'm not as hungry, or I'm not thinking about food all the time. The appetite, the appetite that drives you to eat is quieted, which is nice for some people. Everybody is different. So that's why we've noticed, like in our clinic, we were talking about this a couple of weeks ago, where we'll say, get on this diet, restrict calorie, eat this much, exercise this much, and people lose weight, but not much. Then they gain weight, then they lose weight, then they gain weight, and it's not the person's fault at all. It's genuinely biological. It's the hormones, the wiring of the brain. And so sometimes these medications, we found it pretty amazing because it pushes back past that barrier that we've noticed in our clinic. It's a good question. So big things to think about. So targets the brain. So the whole goal is to rewire, reduce your appetite, hunger, the appetite drive. Obviously not completely, so you don't want to be starving. But that drive where it's like, I want a snack, and it becomes a behavior. It's more psychological. It helps calm that down. It affects the adipose, so the fat cell tissues. It helps push insulin to metabolize some of the fat cells in there, get some of the fat cells out, and then also weight loss. And then what this segues into is muscle. Unfortunately, while you do lose weight, so all these medications, about 10%, 15%, 20% weight loss, that's general weight. That's not talking about fat cell weight. General weight, including water weight and muscle weight. So lean muscle mass loss on GLP-1s alone is about 30 to 38%. So that is pretty significant. So I think when someone is saying, I want to be on a GLP-1 to build muscle mass, it's like, no, it's actually going to be the opposite. You're going to lose muscle mass. You're going to lose some of that strength. So there's ways to mitigate that. And our goal is, trying to make sure that you're exercising well, making sure your muscles are focused, keeping up with your protein. And then when you are losing weight, it's making sure you're losing weight safely. So if you lose weight too fast, you're not able to counteract that with certain amounts of exercise or diet. That's it from my end, because that segues to you about how, so how do we slow down this muscle mass loss? I don't know. If only we had someone who knows about exercise.
Well, thank you. That was great and very
Thank
fascinating.
you. And then we can ask your questions afterwards, or more questions. Oh my goodness.
That was great. Okay,
See, it's a good segue.
perfect segue. Okay, thank you. So I'll start with a little background about Mint Condition Fitness. Our mission is to empower adults 50 plus to take control of their fitness and live the life they envision. Mint was founded by Colin Triplett after he witnessed his grandfather's early decline fueled by overmedication and Alzheimer's. And his vision for helping people, like his grandfather, resulted in us being rated the #1 personal training studio in Los Gatos for adults 50 plus. And we've been fulfilling that mission for the past 17 years in our community. Now, there are some people here who are not members of Mint, and I want to make sure you know about this offer I'll be talking about later. If you end up connecting with what we talk about today and feel like you need help, I encourage you to check out our Thrive in 5 assessment process. This is the starting point for working with us and is designed to help you understand exactly what your body needs to move forward safely and effectively. In that program, you'll receive a comprehensive initial evaluation with me, 2 sessions with a coach to implement a tailored program and to further assess your needs, and a recovery session to help reduce potential soreness and stiffness, and then finally what we call our strength and longevity review, where we take everything we've learned and create a long-term plan for you. The Thrive in 5 assessment process right now is $397, and I do have 5 available spots. So towards the end, you've seen the clipboards at the front. If you wouldn't mind signing in and providing your contact information, check yes if you'd like to learn more about this, or if you'd like to get a copy of the slides from today so you don't have to worry about taking notes or remembering everything. So before I begin, I want to talk a little bit more about who I am, so you know who I am and why I care so much about talking to all of you. So here's my father, a smart, charismatic, and hardworking role model for my sister and I. He was quietly and not so quietly suffering from multiple health problems in his 50s. So wear and tear was catching up to him. He was a trucker for 20 years. So that was catching up in the form of chronic pain, circulation issues, sleep apnea, arthritis, depression, diabetes, high blood pressure, a sedentary lifestyle, and a lack of real nutrition. So if you add all that up, chances are you won't make it long. And he didn't, and died at age 55, about 18 months after this photo was taken. So it takes a lifetime to navigate what happens after you lose someone, as many of you know. And I don't want anyone to have a fate like this at any age. So it's my mission to help people like my father in any way that I can, and being part of Mint Condition has allowed me to do that. So my hope is that today we're able to educate you a little bit and therefore improve your lives. So let's get started. Today I want to focus on the GLP-1 conversation that most people are not having, and we already heard a little bit about it. GLP-1s are everywhere right now, right? Maybe you've seen the ads. Maybe your doctor has brought it up. Maybe a friend is on one. Whatever your starting point, there's something that doesn't get said often enough, and I want to make sure you walk out of this room knowing it. First of all, the science is clear. We heard they're a powerful tool for weight loss. People are dropping significant weight on them, usually more than they've been able to with diet and exercise alone. But here's what often gets left out of the conversation. When you lose weight rapidly, your body doesn't lose just fat. It loses muscle as well. And that's true for any rapid weight loss. It's true for surgery, it's true for crash diets, and for GLP-1s. And for the people in this room, adults over 50, that matters more than it does for someone in their 20s or 30s. So 3 things to keep in mind here. Weight comes off fast. Fat and muscle come off together, and the cost of muscle loss is much higher after age 50. So we heard that 30 to 38% statistic. I'm using this one here today. And it's the number I want you to remember. When someone loses weight without a strength training program, whether it's from dieting or illness or, yes, a GLP-1, research consistently shows that 25 to 40% of the weight they lose is muscle, not fat. So if you lose 30 pounds the wrong way, that's 8 to 12 pounds of muscle gone. 8 to 12 pounds, that's pounds of strength, mobility, metabolism, and resilience walking out the door alongside the fat. And here's the kicker. Your scale is happy, your clothes fit better, the before and after photos look great, so nobody's sounding any alarms, right? And that's why I want to put this number in front of you in the biggest font that I could. So why does this matter so much for the people in this room? Muscle isn't just for looking strong. After age 50, it becomes one of the most important assets you have. So let me run through 5 reasons why. Number 1, strength and independence. Carrying groceries, getting up off the floor when you've been playing with the grandkids, lifting a suitcase in the overhead bin, all of that is muscle. Number 2, mobility and fall prevention. So strong legs and a strong core are your best defense against falling. And falls in this age group aren't just an inconvenience. They're usually the start of a cascade of further problems. Number 3, metabolism and blood sugar. We heard a little bit about this. Muscle burns calories at rest, right? It's also your body's largest reservoir for glucose, so less muscle means a slower metabolism likely and worse blood sugar control. Number 4, joint protection. Strong muscles take the load off arthritic knees and hips and shoulders. If you lose muscle, those joints will just inevitably take a bigger hit. And number 5, longevity. Lean mass and grip strength are among the strongest known predictors of how long you will live and how well you will live. So, lean mass and grip strength are among the strongest known predictors of how long you live and how well you live. Yeah, 2 things that we measure monthly with all of our members at Mint. So when you talk about losing 8 to 10 to 12 pounds of muscle on a GLP-1, we're talking about giving up some of all of this. So here's what I want you to picture. One sec here. Yeah, because the timing matters, right? Stage 1. Here's where most of you are right now. Strong and capable. You're active, mobile, independent. And when something knocks you down, a cold, a tough week, an injury, you can bounce back generally. Stage 2, sarcopenia. That's the medical term for age-related muscle loss, and it's quiet, and the scale doesn't change much, but climbing stairs feels harder. You start avoiding things you used to do, and your strength drops faster than your weight. Number 3, stage 3, frailty. This is falling, hospital stays, loss of independence, and once you're in stage 3, it becomes extremely hard to recover. And the path from stage 1 to stage 3 normally takes decades, but a poorly managed weight loss period, whether it's a GLP-1 or anything else, can compress that timeline. And months of muscle loss can move you years down this curve. And so that's why this matters. Muscle lost in your 50s and 60s is the muscle you'll wish you had in your 70s and 80s. So we've laid out the problem. GLP-1s work, but they accelerate muscle loss alongside fat loss, and that hits hardest after 50. The good news, it doesn't have to play out that way. We see this all the time, and we know how to prevent it. So we'll show you a simple framework that we use with every member who's on a GLP-1 or thinking about getting on one. The framework is 3 pillars: strength training, adequate protein, and consistent recovery. You don't need anything fancier than this. If you do these 3 things consistently alongside your medication or just completely on your own, you'll protect what matters most. So strength training, this is the non-negotiable. It is the single most powerful signal you can send to your body that it still needs muscle. Protein is the raw material. Your body literally cannot maintain muscle if it doesn't have the building blocks. And recovery, this is where adaptation happens. Training breaks the muscle down. Recovery is where it rebuilds. So let's go through each one. Strength training. 2 to 3 sessions a week. That's it. We're not talking about hours in the gym at a time. Consistency matters far more than long, exhausting workouts. When you train, prioritize compound lifts. That's squats, hinges, push, pull. These are multi-joint movements that train the largest, most useful muscles in your body, and that gives you the best returns over time. And progressive overload. That's the magic word. A little more weight, a little more control, a few more reps over time. That's how muscle grows. Doing the same workout with the same weights forever is maintenance, actually, not progress. And especially on a GLP-1, form first, intensity second. Lower appetite, plus lower energy plus possible dehydration is a recipe for injury if you push too hard, too fast. And we've seen that. So be smart about it. Show of hands, how many of you currently do any form of strength training? Okay, good, okay. And now how many of you would say that what you're doing is structured and progressing? Okay, very good. That gap is where most people lose the most muscle. So let's talk about a success story. Lauren. Last year when Lauren first approached me about her intent to take GLP-1s, the first thing she said was, I want to preserve muscle. I only want to do this if I can preserve muscle. Over the past year, and specifically the past 6 months, Lauren trained at Mint twice per week, emphasizing compound movements with increasing resistance like you see here in this picture. And so in the past 6 months alone, as you can see, she lost 20 pounds while losing only 1.2 pounds of muscle, or about 6% of total weight loss, instead of 25 to 40%. Pillar number 2, protein. This is where most adults 50 plus are coming up short. And on a GLP-1, it gets dramatically worse. So a good daily target, 0.7 to 1 grams of protein per pound of body weight. So if you weigh 160 pounds, you're aiming for somewhere between 110 and 160 grams of protein per day. If you're training hard or you're over 50, lean towards the higher end. And the key here, spread it across 3 to 4 meals throughout the day, aiming for about 30 to 40 grams per meal. That maximizes muscle protein synthesis. So basically the meal by meal process by which your body uses to build and repair muscle.
Could you repeat that?
Yeah, so
60 pounds is how many grams?
So if you're looking at 0.7 to 1 gram per pound of body weight, like for example, I'm 200 pounds, a good top end goal for me would be 200 grams, which seems like a lot. A lower end goal would be 140. So yeah. And then the key there is spreading it across meals. Your body, muscle protein synthesis just works better if your protein is spaced out throughout the day. Okay, so that is a big leap for some people, learning to not skip meals and actually have a breakfast. But that's the key. Good question. Thank you. And here's the GLP-1 specific piece. As we learned, these medications work in part by lowering your appetite. That means you're eating less, which means, as I said, hitting a protein target becomes even harder, right? Your calories are limited. So you have to plan for it deliberately. And the people who do this very well are prepping their protein for the day before they get hungry, not after. It becomes part of the plan. Here's some easy wins: Greek yogurt, eggs, chicken, fish, cottage cheese, whey protein, lean beef. It's nothing really exotic. It's just consistent. Okay, Terry, another success story. Terry was able to monitor his protein intake in conjunction with regular strength training throughout this period of dramatic weight loss of almost 50 pounds. In doing so, he was able to limit his muscle loss to about 7 pounds, or about 15% of the total lost weight. Imagine if he had lost 12 to 18 pounds of muscle at age 76. Recovering from that would be extremely difficult. Pillar number 3, recovery. If training is the stimulus, recovery is where your body actually adapts. And if you skip it and you're breaking yourself down without building anything back up. And sleep is number 1. Who has heard this before? Sleep is number 1. Yes. It's easy to say, hey, just sleep better, but there are things you can do to improve this. Number 1, strive for 7 to 9 hours. And to help you do this, you can use what we promote as the 3-2-1 rule. So no food about 3 hours before bed, no vigorous exercise about 2 hours before bed, and try to avoid screens 1 hour before bed. Most of you are probably doing one of those, but small fixes there will pay huge dividends. Number 2, hydration. A reasonable target is half your body weight in ounces per day. Okay? And you can add electrolytes when you're training or it's hot out. A number we promote at Mint is about a quarter of your hydration should be supplemented with some type of electrolyte additive. Last is active recovery on your days off. So that's walking, light mobility work and stretching, swimming. These things keep the blood flowing and keep you mobile and help your body do its work. Also, last point, listen to your body. On a GLP-1, lower appetite means lower energy, and that can easily mask under recovery. If you're also just feeling consistently flat, adjust early instead of pushing through it, right? One more success story. Anne, who is an avid traveler with a very active and social lifestyle. And in the past 7 months, she lost about 17 pounds and only 1 pound of muscle. How did she do it? Again, strength training and protein were critical, but she was also able to leverage recovery to help her body adapt. So sleep, hydration, and stretching became even more important on off days, from her long bike rides and 18 holes of golf and short vacations full of activities. So Anne is another example whose entire life might have been diminished with increased muscle loss. If you take 3 things from today, take these. Number 1, GLP-1s are powerful tools, but they aren't a complete solution. The medication makes weight loss possible. It doesn't make weight loss healthy by itself. And weight loss is not the same as fat loss, especially after 50, as we've learned. Number 2, muscle is your most valuable asset in the second half of your life. Every reason we listed, strength, mobility, metabolism, joint protection, longevity, they all run through muscle, and you must protect it deliberately with strength training, protein, and recovery every single week. 3, the combination of these things is what wins. The medication on its own is fine. The framework on its own is great, but the combination, GLP-1 plus strength training, protein, and recovery, is what produces the kind of results that Lauren, Terry, and Anne are getting. Better long-term outcomes with fewer setbacks. So I hope you're able to act on some key takeaways from today. And if you do want to act on anything we've talked about, you should start to see some progress. But if you feel like you're stuck and need help, this is what we do. Our mission is to help people exactly like you. So if you're interested, please let me know and we can talk about the next steps. But as I mentioned earlier, the best first step you can take with Mint is to sign up for our Thrive in 5 trial assessment program. And I encourage you to check it out. As I mentioned, it's the starting point for working with us and is designed to help you understand exactly what your body needs to move forward safely and effectively. So please remember to leave your information and check yes if you'd like to learn more. This could be a good next step for you. Also, if you'd like a copy of this presentation and weren't able to take notes today. So let's open it up for insights and questions for both of us. So what jumped out at you and what's your biggest takeaways from today? Yes, Herman.
Question, with your experience from having these patients on this medication, and I don't know how long your patients have been on it. So at the end point, when they do lose and they hit their goal, and you stop the medication, what is the outcome? What have you seen happen with these patients?
That should be fine.
Oh, that's a really good question.
Why don't you repeat the questions from the video?
Yes.
Thank you for the question, Herman. So what happens after they stop taking medication? Is there like an expected weight gain or like what's the protocol or how is that managed?
Yeah,
Okay.
Do you continue them on it indefinitely, or do you stop it and see if they gain weight, or do you switch them to another medication? So then if you switch them to another medication, how long does that go on for?
Fair. No, and then the answer is unfortunately tough because it depends. It depends on the person and the situation. There is a chance of rebound. So some people, because of the medication, it enhances the natural hormones that you have in your body. There is a chance of some people gaining weight back. Some people, the hope is with the longer usage, the more rewiring of the brain, so that food noise that drives people's appetite is calm and can stay calm. But stopping the medication abruptly will definitely lead to a rebound, which is why we recommend having a safe plan. So starting the medication while you're on the duration of the medication, and then potentially coming off the medication, you want to strategize how to do it safely to make sure that there is no weight rebound. We've had some people gain some weight back, but typically there's been a lot more talk in the medical community about how do we titrate people off. There's been a lot of, we know a lot about, okay, titrate up. Start off with a low dose and then slowly build it up depending on side effect profile for the person and how much progress the weight goal is making. In terms of coming off, there hasn't been too much information in the medical community. There's been a lot of suggestions about trying it slowly coming off doing a stepwise decrease per dose and then seeing how it goes. Are you able to maintain your weight on this? Good. And then the other factor is lifestyle changes, exercise. Are you able to maintain that exercise? Are you able to maintain the diet? Because it's not a short-term diet. It's a long-term change. All of this is a long-term change. Doing this for 6 months or 12 months or 3 years is not going to sustain you for the rest of your life. So any changes you make now is going to be a change you make, hopefully, for the rest of your life. So some people may need this medication for a longer term, 10 years, 8 years, 5 years, but at a low dose. Ideally, low dose is the best, but everybody is different. If we are trying to push for weight loss, we want to push for it and we may have to go up on the dose. We want to do it safely enough where we are not losing muscle mass. And that leads into a segue for the next topics that we have, including osteoporosis, which is one of my favorite topics. And make sure that you maintain mobility, strength, and movements, because that is very, very important. I take care of a lot of people, especially at the geriatric population. I see a lot of frailty. I see a lot of, unfortunately, fractures and hip fractures and unable to move and unable to get out of bed, unable to bend down and pick things up, or if they fall, they can't get up. It's a major safety issue. So if we can prevent that early on, it'll be so much better in the long term. So it's it's like a complicated answer.
Yes,
it really does depend. So some people, they can come off the medication really quick, especially if they're on a low dose.
Mm-hmm.
But if some people who need a higher dose, and that is okay, that's how their body is wired. Every body is different. If they need a higher dose, we just need to figure out how to come down safely. What is a good long-term dose? And then do they have a good long-term plan? Do they have a good exercise plan? Do they have a good diet plan? And to make sure that they're not gaining weight and they're not losing muscle weight.
How do you pick which one you want, Mounjaro or Zepbound or Ozempic? Which one do you? I mean, certain ones have more weight loss than others, so
They do.
So which one do you pick? I mean, in your practice.
So there is the unfortunate part in medicine that we work with called insurance that unfortunately limits us. So some of them you have to have a certain BMI in order to prescribe a certain medication. Some of them you have to have certain comorbidities like obstructive sleep apnea to apply, or I think cardiovascular disease or history of a cardiac attack. So it's something we're frustrated with because it's hard, and some of these medications are expensive out of pocket. It can cost up to $200, $300 per vial a month. And especially if you're planning on taking this medication for several years, that adds up. So sometimes we have to figure out with insurance which medication can be covered and the side effect profile. So some people are great, have no symptoms, no nausea. And some people, it's as if they're pregnant all over again, and they're throwing up in every toilet every time they take an injection. So it does vary. And then what we typically do in our clinic is we'll try to figure out which one, unfortunately, is covered by insurance. If they're not planning on losing too much weight at first, we'll try with the gentler GLP-1s. And then we do have some samples in our clinic, and we're like, okay, let's test it. Let's see what your side effect profile is before we commit to this medication. Good questions.
How long have these medications been out, and therefore how long are the current long-term studies on them?
Now we've been talking about. They've actually been out for a very long time. Um, Trulicity has been out, I think, now 30 years. It's it's originally was marketed for diabetes because of how it affects the insulin and the glucose levels or the sugar levels in your body. And I remember back in my residency days, one of the reasons why we like Trulicity so much is for whenever you have a patient who has diabetes and are overweight, we're like, we can use the side effect of weight loss because it's a side effect. And now we're using the side effect as the main reason for these medications. We use the side effect of saying, hey, while you're on this medication, your A1C can come down by several points and you could potentially lose weight. And I think all these pharmaceutical companies started catching on to that and like, oh, this is a nice side effect. Let's market the side effect as the main reason for these medications. So they've been around for a while. We're just hearing, and like I think Zepbound and Mounjaro are like the same medication essentially. They're the same exact medication. They're just named differently because it's how the pharmaceutical companies want to sell them, and then on top of that, it's how the insurance company allows us to prescribe them. So if you have diabetes, you can have one for sure; it'll be covered, and if you don't, then it's the other. It's the nuances of the medical world, unfortunately.
And purportedly, come July, they say for Medicare patients meeting certain criteria, the GLP, well, either of these medications, I believe, will be $50 a month.
No kidding.
No kidding. But, you know, I think you have to have a BMI of 30 or 35, I can't remember, or some sleep apnea, cardiovascular disease, something. So
it's only authorized. It's not through your insurance. You have to submit it to, I think, Humana will be managing the authorization of the medication.
it's something through Medicare for sure.
Yeah,
So
so
I
it's through Humana.
haven't started yet, so don't know the details, and I'm still a little like, we'll see.
Yeah, I'm like, we're holding our breaths.
Yeah.
So we're hoping if Medicare can bring down the cost, I think it'll be more accessible to a lot more people. So hopefully, and what a lot of insurances do, they follow Medicare. So if Medicare somewhat sets the standard, so if Medicare decides, hopefully, to put a limit on the cost, then all the other insurances will hopefully follow suit. They usually do about like within like a year, all the other insurance will make policy changes.
Yes.
I have a question for you, Max.
Yes.
I have a number of patients who do Pilates or yoga, and I'm never quite clear on just, you know, how much that should count as strength training, and it probably depends on the class, but I don't know if you have any data or opinions on that.
Yes. No data off the top of my head, but I would say that Pilates and yoga are fantastic for obviously stretching and breath work and core strength and also connective soft tissue, that type of work. But as far as the type of strength training we're talking about, actually, I answered this question from someone who came in and they said, when you say strength training, like what kind of numbers do you mean? And I told them a good target is to be able to lift half your body weight off the ground like this, like base. That's where you should be. And when their eyes popped out of their head when they said, "So you're talking about that would be how many pounds?" That's 10 times as much as they were using at Pilates with that level of resistance. So I think both are great, but the number one things I hear from most prospective members at Mint, I walk a lot. I do some movement at Pilates or yoga, but what really is missing is actual strength training, the compound lifts that are in a weight category that they've never even considered. So bottom line is it's usually not enough. Yeah.
I just wanted to vouch because I do see one of these physicians as a primary care physician, and they are concierge in their office. If there's a problem with it's the prior authorization you have to get through. If your insurance does not cover any one of the GLP-1s, their office works very, very hard to get it approved. Where I'm not knocking if it's a very busy office or some of the other HMOs in the area, they won't even do. You guys won't even you don't even have a chance of getting the prior authorization done.
Wow.
Where with their office, you do. And then the bottom line is, it's just a matter of they know how to jump through the hoops that the insurance companies are asking for their patients to get the drug approved. And then once it's approved, it's generally approved for a year. So you're good for a year unless your insurance changes.
It's also the way how we structured our clinic. I think you're right. We try to get our prior auth. Unfortunately, some medications insurance doesn't want to give it to you right away, so we have to. Prior authorization is a request, a medical request from the doctor who prescribed their medication originally, saying, "Oh, this patient needs this medication because," and so we've sadly have had to deal with prior authorizations many times, and we are at the point where we have structured our clinic enough where we have, I don't want to say time, because I don't think we ever have time, but we do have time to focus on each patient and saying, okay, we really need to push for these medications. So choosing your doctor when starting a GLP-1 or continuing with GLP-1s is really important because you want to make sure you have someone who will be with you every step of the way because it's dynamic, especially with weight changes.
Also for authorization for medications, what you can also do is go online, see who your insurance carrier is. Then you look up the criteria for the medications. Like for Ozempic, for example, a lot of the drug companies will require you to jump through the hoops. Have you tried phentermine? Have you tried Contrave? Have you tried, a lot of the other medications? And then once you say that you have, or there was counterindications, and you said you had side effects to it, then they check off the boxes. If you're pre-diabetic or you're diabetic, did you take metformin for 2 or 3 months and did it fail? But you can go online with AI. You can say, for example, a Blue Cross Blue Shield. What is the criteria they use for authorization for Ozempic? And it'll pop it up right up.
Yeah, Ray? Or
Go ahead.
Julie, go ahead.
What is microdosing?
Ooh, that's a good question.
I'll answer that.
Yes,
I think
you do more.
it means different things to different people, to be honest. So usually what I actually think people mean is just using that starting dose or the second, so lowest dose, so not getting up to max dose. But for example, the Ozempic pen is this kind of funky little one pen, and it has multiple doses in it, and you have to go through something like 16 clicks to get to the actual dose of the first starting dose. So some people are like, I'm just going to do 4 clicks, or I'm going to do. It makes the pen last longer for one thing.
I've heard of that.
But and so that might also be what some people mean by microdosing, that they're even using less than what we consider the starting dose. So I think it means different things to different people, but I think it's one of those two usually.
And I was in a conference. I was in a conference a couple years ago, talking about microdosing to some extent, about tapering off and saying, it's usually once a week injections, but maybe once every other week, and see how your body handles that, or alternating doses here and there, and seeing if that helps you slowly come off the medication. But I think every provider microdoses differently.
Yeah, that's what I was going to say, is that some people have met their target weight loss, but so maybe they do a small dose or whatever dose they were on, but they're doing it every 14 days. Because like you said, there's some brain and, hormonal change, so maybe you don't have the blue noise. It's a maintenance thing, but again, it's all individualized.
I was going to add something real quick just to Tiffany's question. The people who come in who have been doing yoga and Pilates typically have a much lower risk for injury based on our functional movement tests and other screens that we do. So that is something that I do see. At any age, they come in moving way better than the average person. So there's a lot of merit to doing that multiple times per week.
And a lot of athletes, like basketball players,
Yes.
hockey players, are starting to implement yoga. Because usually everyone's like, oh, yoga, it's so relaxing. It's not. It is strenuous. But a lot of professional players, sports players, are actually implementing it. So it's fun to hear stories about like LeBron James, and my brother can attest to all those players. But they implement yoga into their practice, which is really interesting.
Pat, did you have a question?
Yeah. So taking it for diabetes or some general diabetes or prediabetes. Is there any studies, because it's a hormone, what in the long term for people taking it, those type of people generally end up taking it, I believe, longer, maybe?
Lifelong.
Lifelong.
Lifelong
Yeah.
sometimes. Is there any studies, because it's a hormone, of the negative effects that it could have on other parts of the body? It's hormones are tricky, so I wondered if there's any studies like on cancer or anything that it could.
Sure.
That is a great question. There's been a lot of, because we've had Trulicity and Victoza now for 20, 30 years. So there's been a lot of data, and it doesn't necessarily cause, there's no direct correlation. I think the only issue is if you have any medullary thyroid carcinoma or family history of, we're extremely cautious and say, well, please don't do it, and try to find another medication or MEN2.
Yeah.
Although I think then we would say, like, speak with your thyroid doctor about it specifically, and you need to be monitored extremely closely if GLP-1 is the medication you absolutely need. So the medications themselves aren't hormones. They just look like the hormones that, so the hormones have a receptor where it activates the next steps. So it looks like the hormones. So it's not necessarily hormones that we're injecting with GLP-1 medications or GLP-GIP-1 medications. They're just mimickers. So it's not an added hormone medication, but it does act like it. There's no long-term damage that we've noticed, at least in the last 30, 40 years with these medications. And people who do have diabetes, it is great because it does really bring down the A1C level significantly. And on top of that, taking diabetes medicines, sometimes you have to take it daily. So an injection is really nice. It's one injection once a week, and then you can take, and it's usually, you have to take multiple medications with diabetes, so then taking another medication daily, so you're not, it's a combination. But that is very true.
I would just say, literally, almost every day, I get a daily email from like the American Academy of Family Physicians, and I think probably AI has helped this to be so robust. Every day there's a new kind of observational study, which is different than a study where I say, okay, I'm going to take 100,000 people here and 100,000 people here, and I treat this and I do this, placebo and double blind, all that kind of stuff. This is more, we're seeing what's happening. And so the latest was people on GLP-1s having a decreased initial cancer risk, so lower breast, I think prostate, I can't remember all the different ones. And then a second observational study in women who had breast cancer having a decreased recurrence rate. That's not enough to be like, oh, this is a treatment now because it's an observational study. But what I keep kind of holding my breath is like for the observational study that suddenly shows that there's some liver problem or kidney failure. But it's like there's been one eye disease issue that came up in diabetics, like maybe a slight increase in retinal problems, like tiny bit.
I think it's the blindness.
It was in diabetics only, and so they're already an at-risk population. Other than that, I've really seen nothing to make me feel like these aren't safe, and it feels like daily something new comes out saying, oh look, they help for kidney disease too, and cardiovascular, and maybe cancer, and cognition, and so none of that's firmly proven. The cardiovascular is proven, I think, but anyway, I'm very optimistic.
Yeah.
Thank you.
Yeah.
Question. You mentioned that general weight loss also leads to loss of muscle mass. Does that mean that these meds don't actually have any effect on losing muscle mass, that they're not directly related to that, and that it's just a matter of losing weight? Or is there something about the meds that it kind of amplifies it?
To some degree, a little bit of both. And I'm sorry, that's a horrible answer. Because because it affects the way insulin is released. Insulin does act on muscles. So it can either store sugar in there or pull it out. It can work on that. So to some degree, it does change the dynamic of the muscle. And I believe it does affect some metabolism. I think there's a difference between GLP-1 and GIP-1 and potentially even bone absorption, how it affects with the bone density. But muscle mass, I believe it's the sugar levels. It does get rid of fat. It's more of how the sugars get deposited, because you need the sugars to build the muscle. So the way the sugar gets deposited into the muscle to produce muscle mass, as well as the sugar gets deposited into the adipose tissue to produce adipose mass, and it gets changed.
Would that make any difference in terms of the fitness
I think it goes back to that original question about the diet, like really planning on what you're eating. Um, it's going to be under a microscope. Um, that's the best defense that we have at Mint. And one thing I wanted to add earlier was um, a success story I didn't mention up here. The first thing, they said, I want to preserve my muscle. And they also said, I know I'll probably rebound some weight when I'm done with these medications. And so the whole plan on what to eat was based on what you mentioned, was that it's a long-term solution. We're not just game planning during this period of rapid weight loss. The things we were implementing then were supposed to be things they could carry on through their whole life. So I think it really comes down to diet.
And the diet is a major key component. So if you're worried about muscle, like in a lot of athletes, I want to go there too. A lot of athletes who are trying to maintain muscle mass, they're really good on making sure they have enough protein. So the same with the muscle metabolism. Muscle metabolism uses protein and sugar. And so if you want to make sure that you're not losing too much muscle mass, you want to mitigate that with making sure you have a good amount of protein intake. So in other words, when you take medications work, they really do. But how you really want it to work, you want to make sure you strategize for it. So if you want it to work to lose weight, you could just take the medication alone. But if you want to use the medication to lose weight, sustain good weight loss, make sure you have nice, good muscle strength, make sure you have good bone joint health, you want to plan for it. And you want to plan for it carefully with each step. So while you are on this dose, you're slowly ramping up your exercise, you're adjusting your diet. Okay, maybe we need to lose a little bit more. Let's ramp it up to the next dose. Do we need to make any more adjustments in the diet since now you're losing weight and now you're potentially losing muscle mass? Do we need to increase the protein because now your weight's changing? And so at every stage, we're changing. And then even lifelong, naturally, as we get older, everybody's going through changes. We were going through different stages of life and every stage has a different metabolism rate and different medical problems that come up. And so adjusting for all that it's like an active process, unfortunately, like lifelong active process.
Makes sense.
Yeah.
Haley?
Hi. I know that we're going to be wrapping up soon. I've got my eye on the time. I just want to introduce myself. I've got a comment and a question. And that is, so I'm Haley, and I'm the Mint Nutrition and Wellness Coach. So I'm happy to answer any other questions that may come up. My card is over there as well. But one thing, because we have Mint members here and also some people who are not members yet. But one thing that we offer at Mint is an InBody, and that's a body composition assessment. It's a machine that you stand on. Now you might have one at home that's got a sensor, and the thing that's so special about the InBody is that number one, you can do it anytime as often as you want as a member, but it scans your body and breaks down your body composition, which means that fat to muscle ratio. And so you can keep an active read, and we can keep an active read on how you're progressing. And it's so sophisticated that it measures each appendix, so you can see if your arms are lacking muscle or your legs have more or your trunk is particularly strong. So you're hearing this term BMI, body mass index, which is a common term to measure body fat, but it's not considered as accurate. And so the InBody that we have is much more accurate, and so that's a real advantage. It also can tell you your resting metabolic rate, which is how many calories you burn just if you were to sit on the chair all day long. And from that, we can discern where you want to be in terms of calorie burn if you're wanting to lose weight. The other thing that it measures is visceral fat, which is a really serious measurement and something that's not often discussed. And so we can keep tabs on that as well. So just wanted to offer that up. But I have a question real quick, which is about natural GLP-1 activators like Americate, for example. Curious if you have any opinions about those.
Honestly don't know.
Okay.
But that would be interesting.
Okay.
I'll have to look into that.
Okay, great. And we can continue that conversation.
Yeah, and I wholeheartedly agree with the BMI. Unfortunately, it is not the best way to measure someone's true weight, but it is the only thing we have, or the
Yeah.
only thing every physician has, or anyone has by measuring your height and your weight. Unfortunately.
So another nice metric on those in-body reports called your skeletal mass index, SMI, which most people haven't heard of. And there is a number on there that is kind of in the healthy, longevity-oriented range. So that's also good to keep an eye on, and is a little more, it's not the whole picture again, it's kind of like BMI, but it's a lot better to be looking at if you're curious about where you fall in terms of your muscle mass in comparison with your age and height and gender.
And that is a great segue for our next topic about bone health and osteoporosis, because weight loss means you're losing weight. You're losing weight, not just fat, not just muscle, not just water, but a lot of other aspects of your body. And one of the worries we worry about is bones, especially when we worry about osteoporosis. And that will come with age, regardless if you're a man or woman.
Yes.
And diet plays a key role, exercise plays a key role, hormones unfortunately play a key role, and we will talk a lot about that. I'm really excited about that talk because we see a lot of problems with it.
Yeah, stay tuned. That'll be in late August, likely here again, okay? So I think that's our time for today. Thank you so much for attending. We'll stick around for a little bit to answer some questions. Thank you so much for co-presenting with me,
Thank you.
and we'll see you guys at the next presentation.